Welcome to day 2 of the Generative AI and the Knowledge Economy Symposium. This is a joint symposium that we run with Imperial College Data Science Institute. We do day 2 here at London School of Economics, organized by our Data Science Institute. I'm Ken Benoit. I'm the director of the LSE's DSI. I can see Mark Kennedy, who led opened up yesterday's events. He's the director of Imperial's DSI. And this partnership is what has led to this 2-day symposium in this very, very important topic. How many of you were present at yesterday's symposium? That's great, actually. Yeah, so it's really great when we see people that come to both, because there is a different flavor institutionally, but also a little bit of a different flavor of topic. So we're not going to be showing you as much tech. We're going to be focusing on some of the social science topics that we tend to focus on here. So we have a Data Science Institute at the London School of Economics because we think that this integration of data science and social sciences is the only way that we can understand the massive seismic changes that are taking place in the world. There's the only way that we can mitigate against potential harms from this. It's the only way that we can find solutions to some of the world's most pressing problems. That's why we created our DSI in 2020 to help combine the study of data science and social science to focus on the impact of the economic, on the social, and on the political aspects of this massive transformation that's occurring. This is the second year that we've delivered this symposium. It's an annual event, and it's not a topic that is going to ever lack fresh content. Every year, there are things that we're going to be able to discuss that might center around some of the same themes, but with developments that will have basically been unforeseen in the time that we did it in the previous year. And this is such a fast-moving. We could talk about announcements that happened just the week before that are transformative, and the sort of things that we can imagine in future years really taxes the imagination. This is my last event chairing this or introducing this as director of the Data Science Institute at London School of Economics, because I'll be stepping down as director at the end of this academic term, and in fact moving on to another university and ending my time with LSE. So this is a sort of special event for me in that way as well. So. What are we going to do today? I'm going to stop talking very shortly, but I want to introduce the events of the day, and if you stick around for tonight's keynote, you'll see me again. So we have a first panel sitting up here and ready to go, who are going to discuss how generative AI changes the approaches to delivering healthcare and health policy and designing sustainable systems in this area. Our second panel of the day is going to look at the topic of sustainability, specifically AI, and how we can use AI to help foster a transition to net zero. iPads are great until you touch them in the wrong way. And then our third panel is focused on the theme of education and how education is being transformed by AI, and specifically using a team that we've been running some experiments here at LSE about how AI chatbots and other AI tools are influencing structured teaching and learning. And then to conclude, we're going to have a keynote event tonight, which is really more of a public conversation. I'm very pleased that I can say that I will be in a sort of fireside chat public format with Nicholas Lundblad, who is the Director of Public Policy at Google DeepMind. And we're going to live stream that, so we'll have an online audience and an audience that will be present here. Now, we've had a slight change with that because we were going to hold that in the Great Hall of the Marshall Building. We can't hold it here because some fellow who I think he runs the Bank of England is going to be speaking here tonight. In our place. We're going to be next door in the Wolfson Theater, which is a bit smaller of a theater, but we're going to hold the event nonetheless. So for those of you who attend that, we're going to be exploring the trajectory of current AI capabilities over the next 3 to 5 years and what this means for progress. And then after that conversation, there'll be a chance, as with all of our panels, for you to put your questions to us and for the online audience to do the same. So I'm going to now stop introducing this event and welcome our first panel, which is focused on making AI work well in the area of health policy. So turn this over to Miqdad Asaria, who is our chair, and he's going to introduce the rest of the panelists. Thank you very much.
Thank you, Ken, and thank you all of you for attending. So my name is Miqdad Asaria. I'm assistant professor at the Department of Health Policy here, and I am the program director for the master's program in health data science. So we're really lucky today to have this great bunch of panelists who actually come from very different areas, all looking at data science, particularly in the UK health sector. Maybe Anna does a bit more international as well, but coming at it from very different angles. So I'll give them a chance to introduce themselves, ask them a few questions. We're going to do a little bit of a futuristic role play, and then we'll open it out for questions. So we'll give you 10 or 15 minutes, hopefully, to ask them some questions. So let's start with you, Anna.
Hi everyone, Anna Dijkstra, Director of Innovation at Microsoft in our Healthcare and Life Sciences division. I'm an alum of the LSE, so absolutely delighted to be back here. I did my Health Policy and Economics degree too long ago to mention. I spent a number of years after that as a management consultant facing into the NHS, a few years in the NHS, including roles like Senior Advisor to the Chair and Chief Exec once upon a time, and then moved into health tech probably about 4 or 5 years ago. And my role at Microsoft is to look at ways in which technology can enable improvements in healthcare. And as you can imagine, a lot of the time that I spent these days is focused on generative AI. Lovely to be here.
Hi, I'm Anna Studman, another Anna, confusingly. I'm a senior researcher at the Ada Lovelace Institute, which is an independent research institute, and our mission is to make data and AI work for people in society. And I've just finished a project on data-driven systems in healthcare and how they impact on health inequalities. So started off as really looking at the kind of datafication of health during COVID and the digitization of health at that time, and then sort of spawned out into this new frontier of AI and how that's going to interact with existing health inequalities. So.
Hi everyone, I'm Pritesh Mistry. I'm a policy fellow at the King's Fund, a health and care think tank. I suppose confession, I'm a failed academic, so I did want to be an academic, but I didn't quite make the cut. So I did physics at university. I found a career in engineering for a number of years, then found myself in the NHS. So I helped work both in hospitals and general practice to develop new research projects, move that research into implementation in clinical practice, spin out companies, license IP, and create new innovations from an NHS perspective. I now work at the King's Fund, where I lead the policy development for our digital technologies work. So despite my technical background, a lot of the work that we currently focus on is more on the leadership and cultural factors. So technology might be proven to do something in an isolated instance, but how do you scale it across a system that has so much variability, and what are the cultural factors and the environmental factors that maybe stop technology having the revolutionary power it should have?
Okay. Thank you so much. So we've got somebody who's very much kind of at the tech front lines, somebody who's kind of the ethics front lines, and somebody on the policy front lines. So I think we've got an exciting mix. And so maybe we'll start off by thinking about what's going on in AI in healthcare right now, and what do you think is the most exciting thing going on, either in the UK or globally, or both, with AI in healthcare? Is it just hype, or is there anything actually happening?
Do you want to start? Okay. So most of you guys are familiar with the crisis that the NHS is going through right now. There's a lot of recovery happening off the back of the pandemic. The wait lists are pretty long, upwards of 7 million people waiting on that wait list. And some of those people have been waiting over 52 or even 78 weeks, right? So the challenge with the NHS is we don't have doctors that we can knit overnight or nurses we can knit overnight, right? So in order to catch up with that backlog, the expectation is for existing staff to have to do more, and that's really hard because they are already working incredibly hard. So the thing I'm most excited about with generative AI is we don't want clinicians to have to work more. We want to take away the parts of their work that they find the most irritating, and replace that with the stuff that they really want to do, which is to see patients. And we call that working to the top of their license. And so the things that I find really exciting is now there's a lot of work happening to roll out generative AI to do things that they find really boring, like, writing discharge letters or identifying whether certain prerequisites have been met for the next thing to happen. And there's a lot of estimates that suggest that upwards of 30% of a day for clinicians is spent doing that kind of administrative work. So what I'm most excited about is, can we just massively reduce the really painful parts of their workload and free them up to do the stuff that they really want to do, and cut through that backlog to get patients seen more quickly, which ultimately, we're all here to support patients.
Yeah, I think I'm most excited about something that is not probably about the AI in and of itself, but I think we're at this moment where there's a lot of interest in how we are going to shape and approach the way that AI is deployed in healthcare. And I think we have an opportunity at the moment to ensure that that brings in patients and the public, also clinicians, in shaping sort of how AI is deployed, how it would work for them, and to possibly sort of govern this from the ground up, like use this interest and this sort of point that we're at now with developing kind of regulation and looking at different new technologies to bring those sort of grassroots voices in and the frontline expertise in to shaping that. And there's also this sort of uplift in valuing lived experience expertise in healthcare that we've seen, and I think that could tie in really nicely with how we shape AI. So one of the pieces of work that we did at the Ada Lovelace Institute was develop an algorithmic impact assessment it was a case study for data access for AI imaging, which was done with the, I think now defunct, NHS AI lab. But a part of that impact assessment involved a deliberative workshop exercise with diverse members of the public to kind of say how acceptable they felt certain ways of using their data for AI imaging was. So things like that I think I'm excited to see more of in AI and healthcare.
So the thing that I'm most excited about is the potential for AI to shift the balance of power in how decision making in care is delivered. So we all know about the potential democratizing power of the internet. And the potential was that Google and the internet would enable people to be more empowered for their own healthcare. That hasn't really happened as much as we might have liked, and people still use Dr. Google, but maybe not to the extent that we hoped. And I think AI potentially enables this in a different way. So there's a lot of research that's happening out in the States, for example, looking at surgical consent forms, taking that surgical consent form from something that is quite complex to something that is a lot easier, while still incorporating the required legal information and the required medical information, but making it a whole lot more understandable. And then if we start moving that a step forward as well, then you've got multimodal AI, which means it can move away from just text-based stuff to images, voice, animation. So how it potentially enables people to be a lot more informed about their care, a lot more able to have informed conversations and be more control of their care as well.
Amazing. Does anybody want to say anything about pharmaceutical industry and what's going on? So we've talked very much about clinicians, healthcare, but there's this whole other world which seems to be quite excited about AI around pharmaceuticals, drugs, what's going on there. Anybody? Yeah?
I'll talk a little bit on this. So again, going back to the fundamental problem, most of you guys know bringing a therapeutic to market takes billions of pounds, sometimes a decade or more. It's a really slow process, and the result of it is obviously the prices tend to be higher because you have to cover all the cost of the R&D that went into the drugs that do get made and those that don't. So the potential here is for AI to, one, increase the likelihood that the therapeutic, that the small molecule you've been working on for a decade is actually likely to be viable. And the second is to massively accelerate the process, both through drug discovery and then also through clinical development. So I'll give you some examples here. What we call in silico work is, you use AI to identify, what kind of molecules might work for a particular target. And you can use protein folding capabilities to do that. And many of you guys know how hard that challenge is from a computer science perspective. You can, again, use AI to predict whether a particular molecule might be toxic, how it gets metabolized, how it flows through the system, what kind of effect it might have. You can, and real world evidence is a really big focus area here with AI. So how do you use AI? All of the data we have on patients in the NHS, can we use that data as opposed to the data you collect during a formal clinical trial to understand more the effect that a particular therapeutic might have on patients? Of course, it's much more meaningful because it's real world evidence. Finding patients for clinical trials, really, really hard to do. But you can use, instead of having research nurses pour through records to try and find patients that fit a particular inclusion criteria, multimodal AI is really good at this stuff, right? It can, if you want to find 75-year-old women with purple jumpers, it's something that you can do much more quickly with AI, and then you can inform the patient, keep them engaged in the trial, and then keep your recruitment rates up. Again, using AI capabilities. So lots happening in that space.
Amazing. And maybe one of you two could tell us, I guess, the missing piece now. So we've done pharma, we've done clinicians. What about public health and health behaviours? Anything going on there? Wearables?
So there's a lot of research in public health and the use of AI. So there's, I think in Chicago, they're looking at particular diverse data sets to identify children at risk of lead poisoning, for example. And so this is the power of AI. It's massive data sets that are quite disparate. Be able to pull that all together. There's analysis and work being done on social media and looking at how that might give indication for outbreaks of diseases, for example. But also how you then communicate with people. It's similar to what Anna was just saying, in a way that is unique to individuals. So how do you communicate to people in a way that relates to them, to be able to nudge behaviours, to be able to support people to be aware of public health interventions and what's available in their localities as well.
Amazing. Okay, so sorry, did you want to add?
No, that's fine.
Okay, so we've talked about the good, and there's lots of good, exciting things on the horizon. Some of that we're already starting to see permeating bits of the NHS, presumably in other countries that are doing similar things. What about the bad? So what do you think is your biggest concern about AI? So and what's the consequences of getting it wrong? So there's maybe a challenge, the biggest challenge, and what are the consequences of failing that challenge?
So I start? Okay. Responsible AI is a pretty big topic of conversation, I think, with anybody who's working in this space. I think there's some examples out there already of what can go wrong. You can imagine a MedTech device that doesn't, that is meant to work on all skin types and doesn't work on all skin types, that you can disproportionately affect certain parts of the population inappropriately. I don't know if you guys are familiar with this. There's a lot of digital biomarker work out there. It's very, very cool. You hold up your camera phone to your face. It sort of records your face for maybe 10, 15 seconds, and it can tell you about your pulse, your O2 sats, all kinds of stuff that you wouldn't expect. But again, equity is really, really important in this space. I'd say all of the major players in the AI space have come up with an ethical framework of some kind. At Microsoft, we call it our Responsible AI Framework, and we have a number of principles that we work through, which include, fairness, inclusion, accountability, transparency, which is really about when you're creating or deploying AI, how do you ensure that the effect that it's going to have, you've really understood the risks and the effect that it might have, and you've built it in a balanced way. Because the algorithm's as good as the data that you put into it, right? And when we're in an age of generative AI, where some of these algorithms are trained on the common crawl, it becomes even more of a responsibility to make sure that we're using these algorithms appropriately.
Yeah, I think I'd build on that and say that one of the biggest concerns that's sort of undercutting the work that we've done in healthcare as well as public services more broadly about the deployment of AI is that we don't have great metrics at the moment to measure what we think good is, and the metrics aren't always centered around addressing inequalities. So we think that, going along with innovation and kind of exciting, shiny new AI technologies needs to be sort of investment in measuring how these technologies might impact differently upon different groups and identifying what those harms might be, and right at the outset of the development of technology, sort of thinking about how you would measure those harms as you go along. An interesting piece of work that maybe people have heard about is called Standing Together. It's about data standards in data sets used to train health AI technologies, and they're proposing these data standards where any data set that was used as a training data would have these kind of labels, caveats on who the data came from, where its biases might be, what's missing in there, what it should be used for, what it shouldn't be used for. And I think that's a kind of good start to have those sort of benchmarks and have that transparency around what's actually going into these technologies, because we know that as good as and as detailed as NHS health data is, it's still so gappy, and it's missing people, and it's missing people in disproportionate ways. It's missing demographics in different ways, so people are sort of less well represented in health data, and that's what's going into these technologies. So.
Yeah, for me, I think from a policy perspective, my biggest fear is that we end up just doing more of what we continue to do and just apply technology to do that, rather than thinking about what's the transformative potential of AI. So I think that there's a lot of pressure on the NHS, as Anna rightly just said. A lot of the focus is around productivity. It's around how do you release staff time, how do you get the waiting list down, how do you do what we're already doing faster, how can AI be applied to be able to do that quicker and quicker with existing resources as they are constrained. However, that means that it stimulates the market in a certain way, it means the money flows a certain way, then there's certain developments that happen quicker than other changes that might be needed. And as a result of that, as I kind of alluded to at my kind of thing that I was really passionate and excited about, it means that you don't potentially see the transformative potential of being able to give people more power in their pocket to be able to have an AI concierge that provides them with the right tailored advice that they need at the time that they need it. So that for me is, I think, the biggest challenge for the healthcare system. It's trying to keep the plane in the air while it's currently flying, but re-engineering it to be able to take advantage of AI in a way that's transformative for the challenges that healthcare systems face today and what people need right now.
Super interesting. So AI, lots of exciting things happening now. Some big challenges, but they don't sound insurmountable. It sounds like things that people are grappling with. Maybe the bigger picture thinking will come once the constraints of the current situation are eased a little bit. What about if we start thinking ahead, not today, but let's say 5 years from now? So let's play a little game where we each say a couple of sentences building on what the previous person said. We'll go around a couple of times, 2 or 3 times, and see where we get to, right? So it's 2029. I wake up. My sensor on my arm is buzzing, saying something's going on. I put on my glasses. The augmented reality comes up. But I've recently lost my job at LSE. The AI has been outperforming me on teaching scores for the past 3 years, so they got rid of me. So I haven't been able to subscribe to the health plan. So I have to watch adverts. So I have to watch these stupid adverts about these creams and pills that are going to cure my hair loss and my weight loss and all the rest of it. And 10 minutes later, I finally get through to the avatar that tells me that I need to go straight into A&E because it's detected abnormal heart rhythms. Anna.
All right. setting aside your job loss, very, very sorry about that. When I walk into A&E, what I'm not doing is filling out a whole bunch of paperwork, and neither is the clinician filling out a whole bunch of paperwork. Instead, when I walk in, the clinician can see me pretty much rapidly because nobody's been filling in paperwork. I walk into a room and there's a listening device in that room, and in fact, actually, there's a listening and viewing device in that room. That device captures the entirety of my conversation with the clinician. We talk about my job, we talk about the sensor, we talk about the advert for the skin creams and which ones they like and which ones they don't. And all of that is set aside by the AI, and the AI views and listens, picks out all the really important stuff, and comes up with the essential parts that the clinician mentioned, the tests that I need, the bloods that I need, what I need to be getting on with. It extracts that, it automatically puts that into the clinical system, it automatically sends out the requests and the diagnostics, and the clinician says, well, we're all done here. You can go wait in the waiting room, and then you will automatically be pulled by a system to go get your bloods done and to go get everything else done, and I will automatically get all that information. If it's fine, the system will tell you can go home, and if it's not fine, I'll see you back here in a little bit.
And I have had that experience too in the doctors, in the hospital waiting room. Not only have I not had to fill out forms or explain myself, it's all there in my digital phenotype. That is all of my well-being data from my wearables. It's all of my clinical data from appointments, but it's also all of my web browsing data. It's my financial data. And I'm totally legible to this AI system in ways that I couldn't have foreseen. All of my data is health data now, and all of that is going into decisions about my health and what I'm able to access or not access. And I think, well, that's okay, it's convenient, but I have to really grapple with my elderly father, who is just so scared of that situation and actually doesn't want to go see the doctor now because he thinks, and doesn't want to log on online because he thinks that people will just know too much about him, and it hasn't been communicated to him in the right way. So this is a fictional dad, by the way. My dad goes on Reddit, so he's not actually that worried. But yeah.
So thankfully, the integrated care systems have been using the data for their population to be able to understand how best to balance the resources. So people who are comfortable with using technology, like myself, are able to use technology. But people like my father, who are more digitally excluded and not confident or sceptical or scared, also have the capability to access services more traditionally. And so he still has telephone appointments and goes into the doctors and has support in that way. But the technology still supports his care to be joined up. So that's really positive, and it's great to hear that. And then I'm just kind of supporting him to make sure that he's able to access his meds and take his medications on time, because we still have problems with adherence because it's only 5 years and it takes a long time to change people's behaviours. And I look at my phone, it pings up and it tells me, oh, apparently when I went into A&E, it did some biomarker analysis, and it's just flagged up that I might be at high risk of some early neurological conditions, and well, that's a bit surprising because I didn't consent that, and the doctor didn't talk to me about that. And actually now I'm really worried, but thankfully the AI has just scheduled me to have an appointment with a counsellor as well, so hopefully that might help. But that's going to then fill out some forms to make sure that I can access some personalised budgets as well, so I can have access to the right care. But I'm quite anxious right now.
And then I get a call, my phone starts ringing, and up pops the avatar from my health insurance company saying, we've noticed some new health conditions arising. Your premium is now going up 300%. And I'm already struggling to pay the minimum premium that gives me the ad version of the service. So I'm sitting there breaking down in the hospital waiting room, And the person next to me says, "Are you stupid? You're wearing all of your wearables on yourself. Don't you have healthy children that you could put them on? Don't you have pets?"
I'm starting to wonder whether I should take my garment off. But on the positive side of this, the premiums, I know the premiums will start coming down, and I know the premiums will start coming down predominantly because more than 70% of the cost of healthcare tends to be labor, right? It's a very labor-intensive process because people are taking care of you. But also, there's a big balance in terms of the disproportionate costs that go into people who tend to need care, right? So it's something like 80-20, right? 20% of the people bear the large proportion of the cost because they need crisis care. It often happens in the last 4 or 5 years of their life. So I know some of those costs, the insurance costs, et cetera, are going to come down, and that's 5 years from now. I'm going to assume the NHS is still free at the point of care, because we are freeing up people to do so much more for their patients, and we're also more able to predict the needs. Now I'm not going all Minority Report on you, but one of the key things that we're trying to do with the NHS is predict when somebody needs care. And so that point about saying, hey, you might need a neurological consult or really simple stuff. I think these are the people who are likely to have a fall, and we need to make sure that we test their gait, we tape down their carpets, and we reduce the likelihood that they're going to have a fall, because it is not only incredibly bad for their health, and it's actually really dangerous when you're very elderly, but it also saves the quite a lot of cost, which will bring down the hypothetical premiums that I hope we're not going to be paying.
I don't know. Okay, and with some of that free time that the clinicians have, there's more time to think about strategies of where AI is going to be deployed and where it's not. And we've got to a point. This is a bit of a boring one, but we've got to a point in 5 years where there's more of a structure around how we do clinical trials for AI and what that looks like, and how we kind of manage the sort of scope creep of some of these larger foundation models, and how that gets tested in clinical trial and sort of sandbox environments. So there's a little bit more, we've slowed down a bit from the 2024 moving very fast, and there's a little bit more thinking about where this is going to be deployed best in 2029.
This is the last one. So
good. So the aliens arrived. No, let's see. So I've really been benefited from these clinical trials. So I've been automatically recruited into a clinical trial. I've consented. I've got some new meds coming through. My AFib seems to be working out all right. The hair cream isn't, though, so we can't win them all. But then I tripped over the dog, and it all kind of went downhill. I had a bit of a fall. My hip's a bit fractured, so they're taking me into hospital. But the AI has kind of looked at the surgery, and it's done some analysis, and it's figured out, actually, with the way the automatic tools have worked, as well as the surgeon, we think your recovery time is going to be about 3 weeks, and here's some meds, and we've automatically scheduled you for some physio. So then I get wheeled out of surgery, and I've got this plan, and then I go sit on the ward, but it's still falling apart, and there's a pipe over there that's leaking, and there's a bucket underneath, because we're still waiting for the money to come through on the 40 new hospitals. But I'm going to have a bit of physio coming through soon, and it should only take 3 weeks, so that's great as well, right?
Brilliant. Well, thank you so much. So hopefully that's given you some sense of both where we are now, a possible version of the future, some of the big challenges that we have to face. So I think we've got another 10 or 15 minutes open for questions from the floor. We've got mics roaming, so if you put your hands up, and if you have a specific person you want to direct questions to, otherwise just take in general. Yeah, so somebody back in the middle.
Hi, thank you very much for your insights. My name's Alex. I'm a junior doctor, also working at the BMJ as an editor at the moment. I've become very interested in how AI is starting to be used in mental health and talking therapies. But it's more a sort of general question about what do you think AI in healthcare means for use of patient data and in particular sort of consent, patients' understanding of how the data is going to be used, maybe to build these AI models, and also what it means for some of sort of the GDPR rules about right to be forgotten. Is that still possible if we're using patient data to sort of build these AI healthcare models? Thank you.
Who wants to start?
Yeah, I think it's a big challenge, and I think one of the mistakes that we might make is to assume that this is all too complicated to ask patients about. And actually, we've done a lot of work on data stewardship, participatory data stewardship, and asking people how they want their data to be used and what they're comfortable with. And I think there is still a chance to kind of shape that with AI, although it does, I mean, like with the sort of copyright cases with large AI models, it does become a lot more diffuse to like sort of track what data is actually being used, and it becomes harder. But I would just say that, having that kind of thinking about participatory models in order to do that and sort of communicating with the public about it is just so important, because if that gets lost, then the public trust gets lost in it.
I'll add a couple of things here. As many of you know, the AI is often the sexy bit that comes at the end. The really hard part is bringing together the data, cleansing, normalizing, curating the data. I find, especially with ICSs who are trying to do predictive population health management, there's a huge amount of work going into how we pseudonymize the data appropriately, how do we consent patients associated with the data, how do we manage the opt-out. Of course, there are central systems through NHS Spine that enable you to sort of manage that process. And so, yes, it's hard, but it's absolutely not impossible. And one of the ways in which AI is making it easier is some of that really hard stuff around how do we curate data, how do we pseudonymize the data, how do we ensure that, if you've got images that have names emblazoned on them, that stuff can be identified and removed appropriately to enable research purposes, is becoming a little bit easier. It's not easy yet, but it is becoming a little bit easier. How do we automatically change data from FHIR format into OMAP format for research purposes? That kind of stuff is becoming easier. In my experience, working with patients, that's a cultural thing, right? There are some organizations which are incredibly good at engaging with the public all the way through a process. Like, I think Genomics England is one of them. I think Dorset, as an ICS, has built a population health management system called the Dorset Insight and Intelligence Service. It brings together all data across primary, acute, and I think even some community and care and some policing data. Again, it's incredibly powerful because they pull that data together, but they have been working with the public all the way through that process. So governance and the culture around working with patients, it's hard work, and it's worth it in the end. But these things they do take time, and doing them appropriately can slow you down, but it's the right way to do things.
So I think these Gen AI tools are really early doors still, so we're not really sure what's possible and what isn't possible. There's some early research that shows you can take out data, but it's still kind of emerging. I think we shouldn't make assumptions around people, and if we start asking the question around, do you want your data being used in AI, or do you want to have equitable tools, they're quite different questions. And we shouldn't make assumptions around what people are willing to support and enable their data to be contributed towards. Part of this for me is around participatory involvement of the public, but also how we design our tools, which, to be honest, in my opinion, they're not designed transparently, they're not designed well. And so if you look at things like the national data opt-out, it's very unclear how you can do that. The process to do it tends to be writing a letter to your GP. These are things that we should be able to improve so people have trust in the system and have control in how their data is being used. For mental health and talk therapies, there's a lot of good research that's starting to pop out around empathy around AI. And it's really interesting how culturally, how people take a step back and think, oh no, only people can be empathetic, but actually there's a perception of empathy when you use a digital tool as well. And there's going to be a need to shift some of this, and that'll probably happen through generations, as well as how people get normalised to some of this technology as well.
I would like to hear more from you about your assessment, your expectations for the impact of this world on the professional formation of clinical practitioners. So maybe just to add to your narrative, I imagine myself in this not so distant future, sitting there, the doctor, tells me what is going to happen now. I'm starting to probe her and ask, okay, why and what do you think could it be? And I start to realize she doesn't know, because it's just a machine that tells her these things, and she's never had to go through the basics of coming to a diagnosis, maybe being wrong, being told by a more experienced practitioner why she went wrong and so on. So I think there will be a huge impact. And it's not only for clinical practitioners, I think this is more widely for all professions. Yes, it will make life easier for when you know your job, but how do you get to that point when machines are taking over the basic steps?
So I think de-skilling is a potential big challenge, and we talk through it, for example, with robotic surgery, and I think you're right, it's a risk when you happen to have diagnosis and prognosis kind of de-skilling as well. So part of this is how do we move towards that kind of future? What's the fallback plan when the technology fails as well? There's also kind of how much can the AI actually do? And we're still trying to figure that out, and it's going to be a journey, because the data, or the AI, is only going to be as good as the data. And we know there is very good data within the healthcare system, but it's only one perspective. So it's only the consultation information. We don't have the information of what the patient's already done, the over-the-counter medications, the self-care that they may have done, so it's part of the picture. So I think there'll still be need to have that consultation, to have that diagnosis and prognosis, until we can have a whole picture of an individual and that data being fed into an AI algorithm.
And if I could comment, and maybe this is a false analogy, but I don't think calculators made us forget the importance of learning math, right? I think the essential foundations from a medical perspective will all need to be there, right? And all of these generative AI algorithms, or AI in general, tends to feature a human in the loop, right? And we have medical diagnosis, software as a medical device and medical certification capabilities for a reason, to manage care and to manage safety. I think the point of this is, my hope is that the software that is being created is there to sort of enable, to remind, but not to replace. And I tend to agree here. It will only have, I think, very likely a proportion of the information it needs. A clinician will always, I think, have a much broader perspective on all of the information that's out there, and probably be taking in, software information that's probably not available to any kind of software system. And so, to me, it's, if I think about the amount of information that clinicians need to absorb, the rate at which, scientific advances tend to happen, I think that some of these algorithms can help with really simple stuff like, what is the most appropriate guideline associated with this patient that I'm seeing? Okay, can pull it up really quickly. Are there recent clinical advances in this space that actually you can help me find, that help me understand, okay, well, this patient has just gone through this treatment. What's the latest paper on, a different type of therapy that I might consider, or am I slightly out of date on this stuff? But those medical foundations would absolutely need to be there for them to be able to even interpret or understand any of the stuff being given to them by the AI. You're absolutely right to worry. I think we have to manage the possibility of de-skilling, but I think we're building the software as an adjunct, not as a replacement. And I'm telling you to suck eggs. It's obviously very obvious, but I will repeat that several times over the course of this conversation.
I broadly agree with both of you. I think there's an interesting dynamic, though, that we've seen already with kind of algorithmic decision making, or like simpler sort of like advanced data analytics, where if the algorithm is right enough for long enough, the human in the loop maybe isn't as great of a kind of critical lens as it could be, I suppose. So we see that maybe people start to go, okay, well, it's obviously right because it's been right, and it becomes sort of less effective to have that human in the loop over time. So I think that's not always going to happen, but it's something that we need to kind of consider as a dynamic.
Yeah, and I guess it's how it's deployed in the pathway, right? If I think about radiologists, you can have two radiologists read a report, or you can have a radiologist and an AI, and some studies suggest that actually a radiologist plus an AI, can outperform two radiologists. But you still want both or you definitely don't want an only AI situation. I think that there's a potential loss there, and if I'm off the top of my head, I think NHS Grampian has just done some really interesting work in mammography and the use of radiologists plus AI algorithms and finding incidental breast cancers.
Maybe at the back and then at the front. Maybe let's take both of them, and then that can be our final kind of responses.
Hi, I'm Juan. I'm a student of data science and public policy here. And I have a doubt on if you have an opinion on the political economy of implementation of this. Because the problem I see is that, I think Anna said it, that there's cost downsizing because of more efficiency, and normally policies that increase efficiency are resisted by those that their income is affected. And I think it's a political economy problem with the health workers. And because you need to implement tools that are going to increase their efficiency, but also it's going to drive down their salary, because that is their cost, the health workers' cost. I don't know. I've seen this in Chile. I'm from Chile. That a lot of health reforms are resisted by health workers because they demand them to implement things that they are not trying to do, and they don't want to implement because they know it's going to affect their salary. So, no, it's a general question. If any of you have an opinion on this, and what problems have you seen, you should have seen these problems at this stage, I suppose, and how do you saw this on the future?
Let's take the other one as well, and then we'll do a last round of answers.
Hi, I'm Alison Powell. I'm an affiliate of the Data Science Institute, and I have a question that reflects the previous one, which is about what kinds of tasks are being automated and which are not. Because in the area that I work in, we look at sort of theories about expertise and how experts do their work. And both Annas, I think, talked about reduction of the kinds of boring labor on the part of clinicians and automating certain kinds of tasks. And I think this is related to the previous question, because it's a question about what are the increased responsibilities that are then placed on clinicians if they are making much more high-level and difficult and potentially life-threatening decisions without having the routine work in between, which is a different type of work which might actually be more restful. And I think my main question is really about whether efficiency should be the goal. Because we know that when systems are optimized to function at really high levels of efficiency, they are extremely brittle and they actually have great risks of collapse. And I wanted to know if the panel could respond to that as potentially one of the other risks in this area. Thanks.
And maybe before you start answering, I could just add in something. So now in the NHS, they've kind of been pushing this idea of task shifting quite a lot. So we've always been pushing task shifting, but in other countries, saying that more specialized tasks can be kind of shifted down to less skilled workers. And now we've started to introduce these physician assistants in the NHS, and the doctors are in uproar. And once you start putting in AI physician assistants, which is kind of what this sounds like, how does that play into the unions, the doctors' fears of jobs, all of that kind of stuff? So maybe you could just add that into the mix.
Okay, so on task shifting, I think it's been a long journey. I think task shifting, as you kind of mentioned, there's been task shifting amongst groups of staff, and we've had MDT, so a multidisciplinary team, working for a long time in the NHS. Adding AI into the mix, I think, is going to continue to do that. And that links to the question around implementation. So Sorry, just on the kind of the task shifting and working to the top of your license, what we need to be able to do is ensure that the AI supports the individual, so the member of staff, to be able to do their work, and that's been the role around MDT working as well. And so some of the tech that we've seen coming through that's being deployed, for example, is the listening devices that Anna was mentioning. That's being used by GPs already. It's helping to capture notes. They still have the oversight of the GP. It means that they have less cognitive burden. So instead of typing stuff down, listening to the patient, thinking about what they should be doing next, trying to make a diagnosis, they've got less on their plate to be able to do that, and the technology's taken it off. And that's part of the task-based stuff that it's taking away. But then in doing that, there's benefits, hopefully, in reducing cognitive load, but then it still needs to be assessed for value and things like that. In terms of implementation, it's an ongoing issue. When some of the technology may impact people's roles, so task shifting is part of that. It might make things simpler, it might move tasks along, it might make roles redundant. It affects pay, so there's interesting papers around robotics in Japan, I think, where you basically have technology that means that you have less people doing, say, night shifts, because there's less needing to monitor these people in say, mental health trusts. And so that affects people when they work, where they work, how much they get paid, and there is a need for change to be able to have technology to be absorbed. It's trying to understand how we navigate that change that is the challenge, and that means the cultural changes, the leadership roles, how we support people to embrace technology, have technology that works for them, and have the skill to be able to do that as well.
I'd say to a large extent, this is about taking cues from the staff that we're working with, right? To the point about brittleness, I'm, for example, I'm doing a lot of work in primary care, and a lot of that work is about freeing up clinical time, but at no point has anybody said, brilliant, this means I'm going to be able to see another 4 patients a day. I mean, that's absolutely not the point, right? The point is, right now, clinicians, to your, exactly how you said, trying to look at a patient and talk to a patient and type at the same time isn't good for the patient. And when you've got only 10 minutes per patient and the average consultation is 8 minutes or something, and you've got an average of 37 over the course of the day, that's a lot, right? So, and when we have a sustainability issue with being able to recruit GPs and that number is going up over time, we know that the trade-off that we're making now is clinicians potentially seeing even more patients in a day, which is simply not sustainable, or being able to free up quite a lot of time, some of which just goes back to the GP to do whatever else they need, and potentially, if they really want, they may say, well, my days actually become compressed to the point I can manage it. Now, instead of doing an average of 6 sessions a week, I might choose to do a 7th, right? So it's, and I completely get the point about staff being worried and pushing back. I think what we're finding is, if you take your cues of how the tools are deployed based on what the staff are looking for, over time, what that results in is the staff body wanting it rather than pushing back against it. If I look at the latest Royal College of Radiologists report, and radiology is where AI has probably been deployed more than most of the others, they actively call for more involvement of AI, in the lives of radiologists. So, to me, if we're building AI for clinicians the way they want it, in a participatory way, it's going to drive better outcomes for patients. We can't throw tools at people who don't want them. Sorry if that's a simplified answer, but that's how I see it.
Yeah, I think those are both kind of great answers that cover it. I think it's right to question this sort of political context that these technologies get deployed in. You can't just parachute these technologies into such a complex socio-technical system and not grapple with that kind of existing context. So I think it is right to sort of see the deployment of AI in different ways as kind of having kind of political, there are political choices there, and it's right to sort of question what we want our workforce to look like, and what we want for patients as well. So I think those are great questions.
Amazing. So we've come to time. So I think it's been a really fascinating session. My key takeaway is AI is coming to healthcare, so we have to figure out how to deal with it, how to grapple it. There is complicated challenges. If we're not careful, we can go down quite scary paths, so we do need to be aware of them and engage with them, get involved in that conversation as citizens as well as in our various roles. I think it's been a great panel. It's been amazing how much you guys have been on the same page, despite how disparate your backgrounds are. Let's thank the panelists. I'm sure they'll be happy for you to reach out afterwards or through email if you have things you'd like to pick up with them. Thank you so much, and thank you for coming.